Dhabi, and a warm welcome from the pain management team from Cleveland Clinic Abu Dhabi to the Time for Change webinar. We have this webinar in two parts. The part one is happening today. The second part will happen in December, and you will get an email with the date for the December webinar. So today we'll be focusing on the basics, the pharmacology, as well as the psychology for pain management, opiate crisis in making. So we have various topics. We've got great lineup of speakers. So please stay tuned till the end of the webinar. The other good thing is our webinar is recognized for 1.45 CME points from Department of Health. So that's another advantage. So without a further delay, I would start the webinar. I just want to give a few minutes to see if people want to tune in, because we were going to kind of, allow people to sign in. So I'll give another 5 minutes, and then we will start the webinar. In terms of housekeeping, I'm sure you are used to webinars now, but if you have any questions, please do write them in the chat box so we could take the question answer session at the end. In terms of the speakers, I'll be the first one to start, followed by me. Then I have Dr. Amit Verma, who will be talking about the pharmacology of opiates and gabapentinoids. Followed by that, we have Dr. Jaya Batra talking about the long-term side effects of opioid medications. And then we have Dr. Himanshu Chauhan, who will talk to us about the evidence of opiates and gabapentinoids for pain management. And then we have Dr. Kelly Huffman, our psychologist from Cleveland Clinic in Abu Dhabi, and she will explain the role of psychology in pain management. So we have an excellent line of speakers. So just give us a few minutes, and then we will start the webinar. Right, guys. So without further delay, we're gonna start now. Before I start, I would really like to thank Dr. Massimo Lamperti, the chair of Anesthesiology Institute from Cleveland Clinic Abu Dhabi. He's provided an excellent support for us to bring this webinar in action, because there's a lot of work that goes behind putting up a webinar, and we're really thankful to Massimo to provide us the help and support. So let's get going. So this is the iconic building, Cleveland Clinic in Abu Dhabi. So people who are tuning from the different parts of the world, do visit us. It's one of the best buildings, I could say, in the Abu Dhabi. And in terms of disclosures and conflict of interest, there are no conflict of interest. Now, why we are putting up this webinar, a bit of introduction, that pain is such a common symptom. It's one of the commonest symptoms that brings people to the hospital or makes patients seek help. And the definition of pain is an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or described in terms of such a damage. So this is the definition from IASP, International Association for Study for Pain. But the definition got updated in July 2020, and they added the word resembling with actual or potential tissue damage. So the definition I have highlighted 2 points, the sensory and the emotional experience. And the reason I've highlighted the emotional, because back in olden days, we only focused on pain as a bodily phenomenon and ignored the psychology part or the emotional part. And it's very important to provide and look after the patient's body as well as mind in order to get the optimal pain relief. So as per the ISP definition, pain is always a personal experience that's influenced by varying degrees of biological, psychological, and social factors. Pain and nociception are different phenomena. The nociception is basically firing of the sensory nerves, and pain cannot be inferred solely from the activity of sensory neurons. So somebody could be in pain without having activation of the sensory neurons. So there could be a psychological pain. So in Europe, 1 in 5 adults are affected by chronic pain, a huge number, and the number is growing. And pain became very popular because there was news that Lady Gaga halts a tour because of the severe pain. And if you don't know, she suffers with a condition called fibromyalgia, and she described her pain as lava being poured down her body. So pain got a lot of attention when a famous personality like Lady Gaga suffered with chronic pain. So this is the chart from international survey incidence of chronic pain. I'm just going to blow it up. So you could see the incidence of chronic pain is very high in countries like United States, followed by Australia, followed by Great Britain, Portugal, Norway, Sweden, and Denmark. So it's a common condition, and the incidence is growing. The reason for us to put up the Opiate Crisis Study Day, or the Time for Change, as we know from the US statistics, that every 10.7 minutes in the US, opiates killed someone. So it's a big problem. Not only in the US, in the United Kingdom, the National Health Service was accused for fueling the rise in opiate addiction. And we've got lots and lots of news highlighting this fact. There was a Gosport Head Hospital death, so shortened 456 lives. So here, the elderly people, they basically died because of the opiate overdose. And not only in elderly people, even young people are losing their lives to opiates. So this is the death of a very young kid, died because of the fentanyl. So 48.5 million Americans have used illicit drugs or misused the treatment drugs. 997,000 people died because of the overdoses related to the prescription opiates. And the number is basically shocking. In the UK, 24 million opiates were prescribed in 2017, and the opiate prescriptions are rising. So it's actually a big, big worry. Number of people dying because of the opiate-related deaths have record high in England and Wales. 3,700 people died in 2016 because of drug misuse. It's a big number. More than 2,000 of these deaths involved opioids, according to the Office of National Statistics. So it's a big worry. It's a big worry, and then you can see the articles. Now, not only in UK and US, even in the article in Khaleej Times highlights that the prescription medicines are most abused drugs in United Arab Emirates. And unfortunately, I didn't manage to get the right numbers in terms of the statistics, but I can tell you it's a real world problem of the prescription drugs. And that's the reason we decided to put up this webinar, in order to make people aware that what these drugs are and how they work in terms of the pharmacology, and what are the long-term side effects, because not that many patients get told about the long-term side effects of these medications. And unless you make them aware, they will continue taking these medications. So that's the objectives of today's webinar for the part one. We'll go through some opiate crisis and crisis in making. What are the high-dose opiates, long-term side effects of opiates, evidence of opiates, and gabapentinoids in chronic pain. And then we have psychology and its importance in the management of chronic pain. And then we have part two, where we're going to discuss about the interventional pain management, which will include interventions for low back pain, interventions for headache, facial pain, neuromodulation, and interventions for major joint pain. So that's coming in part two in December. Resources. Now, there are many resources about the opioids, and there was a campaign that was run by Faculty of Pain Medicine in United Kingdom called Opioid Aware. The British Pain Society published a lot of material to make people aware. There is information for patients available on the British Pain Society website. There are CDC guidelines from United States highlighting the importance of being opioid aware, and there are opiate calculators. So this is just some resources that I'm highlighting. So we go on the British Journal of Pain or British Society, and these are free to access, by the way. So if you just go on the BPS website, these are free to download and free to give out patient information leaflets. if you're talking about the opiate conversion, a lot of people, when they use the opiates, they always forget that 25 micrograms of fentanyl is equivalent to 75 milligrams of morphine. So if you have a person coming to you in the clinic on 75 micrograms of fentanyl, they're essentially taking about 220 to 250 milligrams of morphine. So it's very important to use calculators in your practice, which will make you aware how much morphine a patient is taking in a day. And this is a very easy to use app. This is a free app called Opiate Calculator, which was basically brought in by Faculty of Pain Medicine, Australia and New Zealand College of Anesthesia. And it just gives you traffic light system. So the opiate dose is less than 90 milligrams, then you will have the green light. If it goes beyond 90 milligrams, it starts to go amber. And once it goes beyond 120 milligrams, it will show you the red. So as you could see here with my pointer, I'm pointing out the green and then the red and the orange. And it gives you all the opiate conversions. So a very, very good resource for you guys to use. So do download it. It's available on App Store and also on the Google Play Store. So let's start with the opiate crisis. And before we talk about crisis, let's talk about history of opium, poppy, and morphine. Where does this all come from? The world's oldest record, opiate prescription, was described in the Sumerian clay tablet about 2100 BC. A Greek goddess from about 1500 BC shows her hair adorned probably with a poppy capsule and her closed eyes disclosing the sedation. So this is actually way too old. So opiates aren't new. They've been known back till 1500 BC. Going on to the next part is the first authentic reference of milky juice of poppy by Theophrastus at the beginning of 3rd century BC. In the 1st century, Celsus suggests the use of opium before surgery, and Dioscorus recommended patients should take mandrake containing scopolamine and atropine mixed with wine before limb amputation. So this was used back in old days. The Arabic physicians used opium very extensively about 1000 AD, and it was recommended by Avicenna, especially in diarrhea and disease of eye. So this was a drug that was recommended like a panacea drug for majority of the pain conditions and before the surgery. Around 1522, the Paracelsus made a reference to opium-based elixir called laudanum, from Latin word laudare, meaning to praise. He describes the potent painkiller, but recommended that it is used sparingly. And I've highlighted the word sparingly, so it should be used sparingly. In late 18th century, when East India Company gained a direct interest in opium trade through India, another opiate recipe called laudanum became very popular among the physicians and their patients. Opium was a huge in 19th century British Empire and was typically smoked out of a large pipe. And I'll show you the picture of the pipe later on during my slides. Morphine was extracted from poppy flowers sometime between 1805 and 1816 by Frederick William Sir Turner. And this was the first time there was a description of the opiate extraction from the poppy flower. He did multiple experiments with the drugs on the dogs, but they all died. And that's the bad news. So the opiate side effects were well known back in 1816, where this drug was trialed on the animals. And unfortunately, all the dogs died. Then he used it on himself and few boys and learned that it was much better painkiller than opium, and it offered a quite few recreational effects. And this is the problem. The recreational effect of the morphine is what makes people dependent on the morphine. It was sold legally over the counter from from cold to menstrual cramps. So I said it was marketed as a drug for everything, all kinds of pain conditions, all kinds of other conditions as well. Now let's focus on crisis in making. Following the Civil War, the veterans who suffered severe injuries were given morphine for pain relief. In late 1800s, pharmaceutical companies began producing synthetic opioids. The heroin became available. So that's basically the dimorphine. It became very clear that these derivatives were addictive, and the United States restricted the import of opium for medical purposes use only. In 1912, the US and the other countries signed the International Opium Convention, which control the import, manufacture, and sales of the opiate. And that's where the industry started to, and the government started to control the use of opiates. Moving on to next, 1924, because of the misuse of heroin, the heroin addict prohibited manufacturing, importation, possession of heroin, even for medical purpose. So heroin became an illegal drug in 1924. Veterans were given opiates for pain relief of acute pain associated with the combat injuries, but many continued to use, and then misuse of opiates once again became an immediate crisis. 1970, additional opiates such as oxycodone, hydrocodone were developed and marketed for pain relief of acute and cancer pain. In 1980, a 5-sentence letter to the editors of New England Journal of Medicine challenged the practice of using opiates only for acute pain. So this is acute pain we're talking about. But unfortunately, they became used not only for acute pain, but for chronic pain. The authors of the letter, after retrospective review of their records, stated only 4 out of 11,882 patients who had pain were given opiates became addicted to them. And this is actually a big lie in the real world. Unfortunately, we do see addiction as a bigger problem with opiates. Subsequently, this letter was cited over 600 times in support of using opiates for chronic pain. So can you believe this? This is the problem. The actual article was, or the letter was mentioning acute pain, but then people started to use that for use of chronic pain, saying that it's not addictive. It's only 4 people got addicted. So this is where the crisis started to get fuel. A number of physicians and pain organizations, including WHO, began advocating more aggressive use of opiates for pain control for anyone who had pain. Anyone has pain, give opiates. That was basically the equation that was used. 1986, the study published in Journal of Pain, based only on 38 patients, concluded that opiate maintenance therapy can be safe. Imagine doing that in today's real world without a randomized double-blind controlled trial, and recommending a drug is basically not possible. But this is what was done, using a small study and telling that, use opiates because it's a medicine that people aren't addicted to, and it's a good way to manage the pain. A number of studies in the subsequent decades, 3 to 12-month follow-up period, indicated that continuing opiate drug therapy in a patient with non-malignant pain was not associated with substance abuse or psychological dependence. Another total lie. Consequently, opiates were no longer limited to acute pain and the pain associated with terminal illness, but also was used for chronic pain. And this is where the crisis started to happen. 1996, James Campbell, neurosurgeon at Johns Hopkins and the president of American Pain Society, said to elevate pain to the 5th vital sign, along with temperature, pulse, breathing rate, and blood pressure. The 5th vital sign, and still used as a 5th vital sign, but I think there is a different way of looking at that 5th vital sign. 1996, Campbell told the audience if pain was assessed with the same zeal as other vital signs, it would have much better chance of being treated properly, which I agree. It's important to treat pain, but then giving opiates is the only way to treat pain where we miss the boat. We need to train doctors and nurses to treat pain as a vital sign. 1996, the American Academy of Pain Medicine and American Pain Society issued a consensus statement of opiates should have a role in the treatment of patients with chronic non-cancer pain. So moving and taking the evidence from 36 patients who were treated for acute pain and then basically transcribing that knowledge to be used for chronic non-cancer pain is where the biggest mistake happened. The initiative was called Pain as a 5th Vital Sign. A pain score above 4 was meant as a trigger to a comprehensive pain assessment and prompt intervention. In 2001, Pain as 5th Vital Sign, Joint Commission of Accreditation of Healthcare Organization, that physician assesses more aggressively and treats the patient's pain, which included use of opiates. So physicians started to use way more opiates because it was a 5th vital sign. It created public awareness. Patients started to demand. Patients started to do doctor shopping. Physicians were told that there's no issues of addictions, start using opiates. Opiates will treat all sorts of pain, acute, chronic, cancer, non-cancer, neuropathic, nociceptive pain, mixed pain. And unfortunately, this is where the problem started. The wake-up call after the crisis. In 2015, the two pain doctors from University of Washington wrote an article in the New England Journal of Medicine arguing that doctors need to think less about the pain levels entirely. And I think this is where we need to work on. Pain levels, the numerical rating scale, is not a good marker for pain management, not specifically when you're talking about chronic pain. In chronic pain, you also want to look at the functional score. You want to look at the quality of life, patient's sleep, patient's function. So this is what is important rather than just focusing on a single marker like numerical rating scale. The measure of good treatment wasn't getting rid of the pain. It was getting people back to the realistic activities that the pain prevented them from. So it's realistic activities is what we need to focus on. June 2016, American Medical Association voted to denounce the use of pain as a fifth vital sign. In July 2016, the Obama administration came and said no bonus payment to the hospital that did a better job of reducing their pain scores. So they realized there was a problem. And this is something that's very important to know. In 2019, Dr. Atul Gawande, and if you don't know Dr. Atul Gawande, is a very, very good speaker, a great author. He said we also have a clear responsibility to help stem the tide of drug overdose deaths. He wrote, adding that responsibility includes counseling the patients preoperatively, to expect adequate pain control to function, but not to achieve zero pain. And I think this is where the key is, telling the patient, if you're expecting zero pain after your surgery, then that's unrealistic. You will be in pain, but the pain control will be adequate, and that's what we need to work on. So in 2017, Haytham Kafrani, a Harvard surgeon, said the goal of pain relief should be 30 to 55% improvement, and therefore the patient should be expecting tolerable levels of pain and not zero pain level. So this is something that you need to keep in mind. And this is just pictures showing you the opium den, where people will go, and you could see the pipe here, and you basically can smoke the opium through the pipe. And this is basically the Chinese style opium pipes that we use. This is a chamber where you could actually put the opium and you can light it up and you can inhale. This is the opium smoking equipment that was also designed back in those old days. And so how do we avoid opiate crisis? And I think these are a few take-home messages. You know, avoiding opiate crisis, it entirely depends on us. I think we need to basically, as healthcare professionals, we need to influence the prescribing practice, and that's the whole purpose of putting this webinar today, is to make you aware. Not everybody's a pain physician. You know, essentially we are all pain physicians because we deal with patients with pain. Even though you might be a general practitioner, you might be an internal medicine doctor, you may be a surgeon, an anesthetist, we all manage patients' pain, and our prescribing practice will make a big impact in long run. We need to provide education to the patient. We need to have some prescribing guidelines in place. We need to reduce the demand of the patient. We need to educate them about the long-term side effects. Once you tell the patients taking long-term morphine is basically having an overall negative effect on their body, you will be surprised how many patients will say, you know what, nobody told me this. You are the first doctor telling me, and I would really like to come off the medications. You provide the support to the patients who are keen to come off the opiates. You reduce the diversion, you reduce the harm, and the provision of naloxone is something that United States government implemented in order to prevent the opioid-related respiratory depression and the death. So with that, I'm going to end my talk, and I hope you are enjoying. But as I say, the take-home message, we all can do our bit. We all can play an important role averting the opiate crisis by educating our patients, by supporting them and helping them, and supporting our colleagues as well, and educating our colleagues. If they need help, we're there to support you. So what I'm going to do, move on to the next talk, and it's a real pleasure. It's a real pleasure to invite my colleague, Dr. Amit Verma, here today. He's associate staff from Cleveland Clinic in Abu Dhabi. And Amit has a special interest in musculoskeletal ultrasound and interventions for musculoskeletal pain, low back pain. And he's going to talk to us about the pharmacology of opiates and gabapentinoids. So Amit, the stage is all yours. Thank you. You okay? Share the slide.
Trying to switch on the Microsoft Teams, and okay, the mic is on, right? You can hear me. And
yes, we can hear you.
So let's go to the presentation.
Yeah, I can see you, and I see your slides. Though. Can you see your slides? Can you? No, you need to share the slide. Back home.
Can you see my
slides? Yeah, go on the presentation mode and you're good to go. That's great. Thank you. Fantastic. Yep, presentation mode.
Yeah, going into that. All right. Good evening, everyone, and thanks, Dr. Sadiq, for taking all the efforts to bring this on. And thank you, everybody, to join us on this beautiful Monday evening. Hopefully, it will be more productive for you, and you will get some good points to go home. I'll be talking more about opioids and gabapentinoids. It will be very much brief pharmacology and physiology. But yes, I'll talk a little bit also about the physiology of the pain. So the urgency of treatment of pain when it becomes really bad.
Sorry to interrupt, Amit. I think we cannot see your slides, so let's go back to the presentation mode. And these are your slides. Folks, can you see?
Can you?
Yeah, fantastic. Well done. Thank you.
All right.
Thanks so much.
All right. Thanks, Sadiq, for the help. Right. So yeah, I'll be talking about the opioids and gabapentinoids, their pharmacology. It will be a little brief pharmacology. We'll just run through the important parts of it, and also I'll talk a little bit about the physiology of the pain. So the urgency of treatment of acute pain and the efficacy of opioids resulted in something called opioid crisis. So what's common among these three pictures? Elvis Presley in around 1970s, Heath Ledger in around 2008, and Prince in 2016 all died of opioid overdose, and this coincides very well with the chart which was given by CDC. The opioid death started rising around 1999 when the opioids were available to be used, and then around 2010 the next surge when the street drugs were available to the people, and then around 2016 was a new surge in the opioid deaths, which was again related to the use of synthetic opioids, which were much more stronger and much more potent than what was available in the past. So again, yes, is this problem only in US? No. There was a nice study which was done in the National Rehabilitation Center in Abu Dhabi, and they found out that pregabalin was the most common drug of abuse in UAE, and also it has been brought down in the newspapers, and also this was a recent case where a young guy stabbed his father around 36 times because he was not given money to buy drugs. So the problem is nearing UAE also, and we have to make all the efforts to prevent the crisis developing here. I'll be talking about clinical pharmacology and opioids of gabapentinoids, but before we go into pharmacology, we definitely need to know a little bit more about pain physiology. Well, yeah, if we discuss pain physiology into detail, it's going to take a lot of time, but let's go and simplify it a little. We know noxious stimulus from the peripheries transfers to the brain through the dorsal root ganglion utilizing A delta and C fibers, and the normal touch or the gross touch goes through the A beta fibers. But what we would go into a little more details, because that's the place where opioids work, is around the dorsal root ganglion, where the primary and secondary afferent neurons merge. So you have primary and secondary afferent neurons, and then you have the three more important neurotransmitters, the glutamate, substance P, and CGRP, calcitonin G-related peptides, who work and promote pain. So when they are released, glutamate acts on NMDA receptors and AMPA receptors, and when it acts on that, it promotes the entry of calcium and sodium inside, which causes polarization and transmission of the waves. When substance P acts on non-cephalin NK1 receptors, it stimulates an arachidonic acid pathway, which ultimately stimulates protein kinase C. Now, protein kinase C, what it does is it removes the magnesium blockade of NMDA receptors, and thus causing much more calcium entry into the cell, and thus propagation of the pain stimulus. Now, CGRP acts on CGRP-related peptide receptors, and it causes changes in the gene expression, which results in the changes in the receptor activation and expression, thereby resulting into the central sensitization, which is caused by chronic pain and persistent pain in a patient. Now, what does how do we control the pain? Now, body luckily has three of the endorphins, called endorphins, enkephalins, and dynorphins. Together, they act on the four receptors, opioid receptors. We have mu receptors, delta receptors, kappa receptors, and a newly detected nociceptive orphan and Q receptors. What they do, they act. These receptors are 7 transmembrane signaling receptors, and they work by cyclic AMP. When the endorphins act on these receptors, which again is a site for our opioids also, it results in reduction of the CAMP. And when the reduction in CAMP happens, it reduces the entry of calcium into the cells. Now, reduction in the calcium causes reduction of the release of the glutamate substance P and CGRP, and that is how it reduces the pain transmission or pain propagation. They also cause hyperpolarization by causing a potassium efflux, and thus making the cell much more resistant to the transmission of pain. Now, but this is about the pain. So, but what does it do why does opioid diversion and abuse happens? We know that the opioid receptors are present in brain and brainstem, spinal cords, to a small extent in small intestine, and to a very minimal extent in the peripheral terminals and the peripheral fibers. Now, when somebody takes opioids, what does it do? It acts on the receptors for pain, so it causes reduction in the pain. It also acts on the pain on the centers like amygdala, which causes reactivity to the pain, or limbic system. So it suppresses that, but it also acts on nucleus accumbens. Nucleus accumbens is the center of reward. So when somebody takes opioids, they also feel pleasure, they also feel euphoria, they also feel happy, and this becomes a reflex. This becomes a reflex like Pavlovian's reflex. So every time a person takes pain medication or opioids primarily, they also feel happy and euphoric, and this reflex slowly and steadily develops into addiction. So when somebody doesn't have opioids, not only they feel pain, they also feel depressed, and they feel the withdrawal. Now, opioids can be classified by their origin. So we have naturally occurring opioids, semi-synthetic, and completely synthetic opioids. Naturally occurring opioids are morphine, codeine, and thibane. Semi-synthetic, heroin and morphine, buprenorphine. And synthetic are pentazocine, buprenorphenol, phenylpiperidine medications like fentanyl, sufentanil, and L-fentanyl. The next way to classify opioids could be based on structure. So you can have morphine, the medications which have structure of morphine, like nalorphine, buprenorphine, naloxone. You can have medications which have phenylpiperidine structure. The medications included are pethidine, fentanyl, sufentanil, L-fentanyl, and remifentanil. Butorphanol is a morphine derivative. Ben's morphine derivatives are pentazocine, and methadone is completely unrelated to morphine structure. point. Now, we can also classify morphines as pure agonists, agonist-antagonist action. Some of them are just partial or weak agonists, and pure antagonists. So we know pure agonists are morphine, fentanyl, sufentanil, pentazocine, and nalbuphine are agonist-antagonists. Buprenorphine and butorphanol are partial, and then we have pure antagonists like naloxone, which are life-saving. Now, elvimepan is a new antagonist which is being used recently to prevent the post-operative ileus in the post-operative patients. Now, coming to pharmacokinetics, there are various routes of administration. Opioids are available oral, IV. Now, subcutaneous fentanyl patches are available. We do have sublingual fentanyl available. So almost most of the routes are available. Bioavailability of these medications depend on first-pass metabolism. Onset of action depends mainly on the route of administration. Metabolism could lead active and toxic metabolites, so we should know exactly what are the metabolites of the opioids we are giving and what could be the effect of them. Then some patients, some people have variability in the presentation and the expression of cytochrome enzyme system. So like around 20% of the people might take tramadol and codeine and not feel any relief with them because they do not have the cytochrome P450 enzyme metabolism, which would result into the active formation of the active metabolite. Some opioids do undergo enterohepatic circulation, but most of them are excreted by kidneys. We know so in the pharmacodynamics, all of them cause analgesia, they cause sedation, euphoria, and dysphoria. Respiratory depression is an important thing to be thought about. They all cause bradycardia and hypotension. They reduce gut motility, cause nausea and vomiting, urinary retention, and also causes reduced ACTH release. Now, what are the opioids we have? We have a lot of opioids, but then we can look at the opioids which could help us in immediate and acute pain relief, and then something which could be used for long-term pain relief. So what we have are hydromorphone, morphine, oxycodone, tramadol, and tapentadol. These medications can be used for acute pain relief. The doses are pretty much available wherever we want. So approximately hydromorphone could be 2 to 4 milligrams, but and the half-life is around 2 to 3, so it's short-acting and can be used in the acute pain relief. For the chronic pain relief or for longer duration of action, we will have morphine, oxycodone, and then there are multiple varieties or multiple formulations of oxycodone available. Some of them are fast-acting, short-acting, some of them are long-acting, and all of them can be used depending on what type of pain we have. Patches are available. Buprenorphine patches are the most commonly used patches now because of duration of action is long and it has multiple mechanisms of action. Fentanyl patches available. Again, hydrocodone, hydromorphone. So we have a variety of medications available. But I will specifically talk about 2 medications, methadone and buprenorphine, which are actually which help us in averting opioid addiction or opioid overuse or opioid dependence. Methadone, we never use it as a first choice. It is always started. It is never started in an opioid naive patient. Once you have realized that a person is going to be on opioids for a long time, that is when you try. It is very well used in chronic pain, cancer pain, and also in opioid substitution or in opioid rotation. It's a mu agonist and it has coexisting NMDA antagonist action. It has sodium channel blockade. It reduces serotonin and noradrenaline reuptake. So it has multiple mechanisms of action. That's why it is very, very potent and very effective. But we need to closely monitor the patient. One of the most dreaded complications of methadone is ventricular arrhythmia. So anybody with QT prolongation should never be given methadone, and you should always have a ECG done, 12-lead ECG done before you start somebody on methadone, and then a regular ECG monitoring should be done. It has amazing bioavailability around 30 to 100%. Half-life is varies because it gets absorbed into the third space and then slowly gets released from there. Initial dose is around 2 to 5 milligrams, and it can be given 8 hourly, and then ultimately maintenance dose can go up to 20 to 30 milligrams per day. Anybody who's been started on methadone should be followed up around 3 days later. And when you are switching from morphine or any other opioid to methadone, there should be a reduction of approximately 75 to 90% and then escalated enough. Now, buprenorphine is a weak mu agonist, but it has high affinity and low intrinsic activity. It is very, very useful in opioid use disorder. Buprenorphine is available in sublingual and intravenous, but what we have here are mostly, so we have sublingual tablets, but we don't have buccal tablets, and we have transmetal dermal patches. Approximately 30 morphine milligram equivalents is equal to 75 micrograms of buccal or 5 micrograms per hour of transdermal patch. We will look at the conversions later again. The advantages of buprenorphine are it has less chances of addiction, less chances of hyperalgesia, which can be associated with opioids, and also less chances of respiratory depression. Tramadol and tapentadol again is something which can be thought about as a medication which would have lesser opioid addiction and chances than other opioids. They act on opioid receptors and descending inhibitory pathways. Tramadol enhances both serotonergic and noradrenergic pathways, but tapentadol only acts on noradrenergic pathway. And that is how tapentadol is safer in patients who are taking antidepressants, SNRIs, or tricyclic antidepressants, so that the chances of serotonin syndrome are much less. So how do you avoid overuse? It's better to avoid overdose because opioid withdrawal symptoms are present but not life-threatening. It is important to remind the patients and relatives of slurred or drawing speech, ataxia, nodding off during the snoring, nodding off during conversation, or increased snoring and apnea spells at the night. So this should be monitored by the relatives. There should be a tolerance check. Contact the patient 3 days when you have instituted a new opioid. Patients who are elderly, who are on benzodiazepines, on renal and hepatic impairments, patients who have COPD, sleep apnea, and cognitive impairment have higher chances of opioid overdose. And again, we have to be cautious during pregnancy. So you have a person on opioids very high, and then you want to switch to something which is lesser lesser on the side effects wise. You determine so you need to switch, and when you switch, you determine all the current opioids a person is taking. Then you use the calculations to convert them into the morphine milliequivalents. Formulas are available, and there are formulas which are available even for the patches. Very simple. And once you have converted it, then you identify the daily morphine equivalent doses. Then you define how much of conversion reduction would you do. So always reduce by at least 30%. And if it's an elderly, we will reduce by 50%. Now, once you have converted, use conversion factors to convert new opioids into the new opioids. So you can convert to any of the medications which are available in the market. But if you're moving to patches, again, there are simple and different formulas. One of the simple formulas are if you have somebody who has a patch strength of whatever is the patch strength, approximately half of the patch strength is equal to the total morphine requirement per day. Now decide whether you would change to the new opioid, as which opioid you will choose, would you use a PRN or whatever. And then after you have converted, you would schedule a review after 3 days to make sure that you understand the pain control is good and there are no side effects. From here, we would move on to gabapentinoids. These are the new medications which can be used as an alternative to opioids, and they are much more safer. Okay, so gabapentin was synthesized in 1977 as a structural analog of gabapentin with higher lipophilicity for better CNS access, but neither is a GABA mimetic or nor does it bind to receptors of GABA. Rather, it bound to presynaptic alpha-2 delta receptors of voltage sensitive calcium channels. It was applied for epilepsy in 1993, not used primarily. It is used for complex partial seizures and chronic pain. Pregabalin was introduced in 1991 for neuropathic pain and epilepsy. And a new drug has been introduced now, mirogabalin, which is primarily used for diabetic neuropathy, which has been tried, not used till now, but diabetic neuropathy, fibromyalgia, and postherpetic neuralgia. So this was a landmark paper which showed us that the gabapentins actually and gabapentinoids act on the alpha-2 subunit of calcium channel. So there are multiple alpha-2 delta proteins subunits are present vastly, almost into quite a lot of structures, including skeletal and cardiac muscular tissue. But alpha-2 delta ligands are our gabapentin and pregabalin have no effect on non-neural tissue. They primarily affect on neural tissue and work there. They decrease the presynaptic calcium influx and reduce neuronal calcium current, but they do not work on normal neurons. So if somebody doesn't have pain, somebody doesn't have neuropathic pain, they're not going to work on it. They worked on neurons who are overexpressing alpha-2 delta subunits. They reduce glutamate, CGRP, and substance P release too, and they reduce neurotransmitter release. Reduces abnormal network hyperexcitability, and then it causes analgesic and anxiolytic effects. Some important points about gabapentin, we know it, I've already talked about. Now it is absorbed by means of low capacity amino acid transport systems in the gut. Though less convenient, but more frequent doses of gabapentin actually results in more bioavailability. Drug does not bind to plasma proteins and is not metabolized. It is excreted entirely in urine and corresponding with creatine clearance. Gabapentin should be taken at least 2 hours after the antacids, since concurrent administration of aluminum antacids reduces its bioavailability. Now, because gabapentin doesn't have a linear pharmacokinetics, a new inactive gabapentin has been synthesized, and it is absorbed throughout the small intestine. It is metabolized to gabapentin in the intestinal epithelium by non-specific esterases. It has been used in once a day or BID doses and also long-release formulations. Studying in fasted and fed states, it's available in USA and Japan. It has a very good bioavailability, and it has been approved for use in USA and for rest leg syndrome and post-herpetic neuralgia. Pregabalin, that's the new what you call that's another one gabapentinoid. It also is absorbed at a high. I mean, it is so intestinal absorption is dose dependent. It is linear. It also is transported by the low capacity amino acid terminals. Bioavailability is not dose dependent, and hepatic metabolism is negligible. So if we compare, bioavailability of pregabalin is much higher than gabapentin, and that is the reason why it is a lot of times preferred by people who are seeking addiction. And the effect of food on bioavailability is minimal with pregabalin, and around 40% reduction increase in area under the curve for gabapentin. So there's not much of a metabolism, and most of the drugs are directly excreted in the kidney. They are used in pre-herpetic neuralgia, restless leg syndrome, diabetic neuropathy, and post-herpetic neuralgia, fibromyalgia, and spinal cord injury. Adverse effects are sedation, dizziness, ataxia, asthenia, weight gain. Respiratory depression has been reported, but it is much more reported in concurrent use with opioids, and not only alone with gabapentinoids. But are they misused, or is there diversion is happening? Yes. There is a strong evidence of current evidence of abuse and misuse of gabapentinoids, and it has been talked about in the papers and in the media. That's all from my side. I will now invite Dr. Jaya Batra, who is our female lead in chronic pain. Dr. Jaya Batra is our associate staff physician, and she would be talking about long-term side effects of opioids.
let me chip in. So thank you so much, Amit. That was a great overview you gave about the gabapentinoids opiates and made the topic more interesting, because usually the topic like pharmacology is always boring. I found it a very boring topic during the medical school period. So, right, let me just share this. So I'm just going to make sure that we're able to. Right, are you able to see my slides? No. Right. Let me just stop presenting. And
now we can see you.
Okay, 2 seconds. So I'm going to go on to the long term. Yep. Can you see the slides for long-term opiates? Yep. So long-term side effects of opiates. That's Dr. Jaya Batra. It's a pleasure to have her on the webinar. She's our associate staff physician. She basically specializes in general pain management, acute pain management, as well as the pelvic pain management. In addition to that, she has an active interest in the opiate dependence addiction. She sits on a committee where she plays a very important role. She's written up the guidelines and have worked on the minimizing the opiate addiction in the UAE, in the region, and also looks through the guidelines for CCID. So thanks very much, Jaya. The stage is all yours.
Okay. Good evening, everyone. I'm Dr. Jaya Batra, Associate Staff Physician working at Cleveland Clinic, Abu Dhabi. So today my topic of discussion is about the long-term side effects of opioids. Till now we discussed about the opioid pharmacology, opioid crisis, and now we'll discuss some of the side effects of opioids which are really worrisome and about which we should be mindful. So this is a place where we all work. It's Cleveland Clinic, Abu Dhabi. And I'll just switch over to the next slide, which will be about the common indications why opioids needs to be prescribed for non-cancer chronic pain. So for cancer pain, for a long time, opioids are a mainstay of treatment because we have to make these patients pain-free. But in chronic pain, the place of opioids is very, very limited, and it has a very specific role, and it comes into the second or third tier or maybe the last resort of treatment. Common indications in which we use opioids for chronic pain are chronic low back pain, osteoarthritis pain, some of the painful diabetic polyneuropathies, postherpetic neuralgias, in some cases of phantom limb pain. Chronic pain after spinal cord injury is one of the major indications. Some painful non-diabetic polyneuropathies. Restless leg syndrome and Parkinson's disease patients also require, at times, the prescriptions of opioids. Now, do we have any evidence-based, like in which conditions the opioid should be prescribed in these conditions? So I went through some papers and I found that we do have some level of in evidence. And for short-term prescriptions, the level of evidence is 1A or 1B for most of the conditions we just discussed. But for intermediate term, which we term from 13 to 26 weeks, the level of evidence is only 1A for chronic low back pain and osteoarthritic pain. Other than that, all the indications carry level of evidence 5. Now, what is long-term opioid therapy? It is if the opioids are prescribed for more than 26 weeks, we have very low evidence for most of the indications, except again, chronic low back pain and osteoarthritic pain. Now, what are the common side effects which are seen after opioids prescription? It involves many systemic problems. Most of them are concerned to GIT, CNS, cardiovascular, respiratory, and your endocrine functions. We will discuss all the side effects one by one in detail according to the systemic involvement. So first we go for the GI symptoms, which are the most common symptoms presented by patients on opioid therapy. Usually in every system, we have we can say a package made in which opioid prescription is associated with some antiemetics or any laxatives, because these are the most common symptoms which patients present to the physicians. Now, nausea is present in almost 25% of all the patients prescribed opioids, and constipation is present in almost 45% of the patients. Most commonly, receptors which are involved are nu and kappa, and there are also some cases of bowel obstruction seen on chronic opioid therapies. Do patients get tolerance on these effects? So majority of the side effects of opioids, patients do develop tolerance except constipation. So this is a very important point for which every opioid therapy should be associated with a motility increasing laxative, and it is a must for all the chronic opioid patients. Next, we go for musculoskeletal side effects, which are seen on long-term therapy. Especially in elderly patients, the real risk of fall is increased, and we compared the relative risk of any fracture in patients on opioids compared to non-use of opioids, and it was very high, around 1.38. And to the surprise, this rate was even comparable to the risk associated with benzodiazepine and even patients on antidepressant therapy. Now, the second most important system which is affected by chronic opioid therapy is the respiratory system. We already discussed in the previous lecture by Dr. Amit about the respiratory depression caused by majority of the opioids, mostly the synthetic opioids and opioids in high doses. But if the therapy is not guided properly, patients do get sleep disordered breathing, and it has a very, very high prevalence, around 75%. This is normally diagnosed if the patient is inpatient in the form of hypoxemia, carbon dioxide retention, and central sleep apnea. Respiratory depression can be there in patients who are on very high doses of opioids, and we don't monitor them for long, and they can even go to very serious levels, even on ventilators, on high doses of opioids. Next important system which is affected by chronic opioid therapy is the endocrine system. We do have evidence of suppression of HPA axis and hypothalamic pituitary gonadal axis, which is present in both the sexes with consequent hypogonadism and adrenal insufficiency. These effects are generally dose-related and can lead to amenorrhea and infertility, and also reduced libido with associated depression and fatigue. Now, if the patient is showing any symptoms of any endocrine dysfunction, it needs to be monitored, and there has to be a referral to an endocrinologist. There is no evidence that there should be a routine monitoring of endocrine function while on opioid therapy, but yes, if the patient is having any symptoms, then it needs to be monitored. The most important of all the side effects which comes in chronic opioid therapy is related to CNS. Most commonly we see when we start the patient of opioid therapy, they do have some kind of sedation, ultimately to which they get tolerance, and it improves with time. Second most important concept is about the hyperalgesia, which I will discuss in the next slide, and about the drug overdose and drug diversions. We'll discuss all these details in next slides. Now, what is known as opioid-induced hyperalgesia? In acute pain management, we do know about the hyperalgesia, which usually presents after a remifentanil infusion or high doses of morphine given to a patient in acute pain management. But in chronic pain patients, clinically, it is diagnosed as patients which present with increased pain while on long-term opioid therapy. It is very, very diffuse, and it is different from the pre-existing pain and very less defined in quality. Difficult diagnosis to make, but yes, we have to manage this condition by reducing the dose or by doing an opioid switch. The best agents to do opioid switch while on any opioid therapy are buprenorphine and methadone, for obvious reasons which we already covered in the pharmacology by Dr. Amit. Common mechanisms which were enlightened for opioid-induced hyperalgesia involves the involvement of NMDA receptors, increase in spinal dynorphins. There are some genetic mechanisms in the background, and some neurotransmitters which involves decreased reuptake of neurotransmitter from primary efferent neurons and activation of neurons in rostroventral medulla. Now, next we will talk about something which is known as drug diversion. It's a very interesting thing which we all know, but it is often ignored in our prescription settings. What exactly drug diversion means? It is a medical and legal concept which involves the transfer of any legally prescribed controlled substance from the individual for whom it was prescribed to another person for any illicit or recreational use. Now, drug diversion is not limited only to the patient. It also targets the healthcare professionals. If you look at the triangle, in the top part, the blue part, this resembles the patient part, which may be under pressure or some motivation, some external factors or some internal factors, which includes his dependence, increased pain, distress, or external factors, which include some lifestyle, some debt, some family needs, which makes him under pressure to divert the drugs which are prescribed for his own use. Sorry. Now, second important point, this is a point which we target on the patient side, but it also involves the healthcare professionals who have the opportunity and who can justify the drug prescription, but it is done in a wrong way. Now, what do you mean by the opportunity? As healthcare professionals, we have increased access. If suppose there are weak internal controls or there is weakened security, or if there is too much trust and the person is not in the right mindset, there may be chances of increase of drug diversion. Also, some healthcare practitioners can be under a justification that my job owes me to prescribe if the patient is asking it, and they can say that we are responsible for dealing with the pain and they are in a pressure to prescribe it. How do we diagnose that a healthcare professional is doing a drug diversion or a patient who is taking a medication is doing a drug diversion? Now, if we have some red flags which we can find out, we should take them seriously. Now, if we find anything like a prescriber is doing same prescriptions for all the patients, there is inappropriate drug choice. Now, and the patient is coming to the pharmacy with always cash payments, and he's not aware about the drug's purpose. Patient is very young and very mobile, but still taking very high controlled medications. These are all some red flags which can make you suspect that there may be a potential for drug diversion. The method to deal with this condition is to have a drug diversion monitoring program at your organization. We did a survey about this, and we found most of the organizations know about it, but they don't have a concrete system in the background. Only 43% of the organizations, they say that we monitor, but we do it manually. Automated system is present just in 32%. Rest of the organizations, they are not having the system or they are still planning on it. But it is an important safety issue which targets both the patient as well as the practitioners. Now, we have talked enough about the drug overdose in the previous lectures, but I would like to have some overview about this chart in which we see that opioids alone definitely are very dangerous if they are given in an overdose, but polysubstance combination with opioids is much more dangerous than single opioid prescriptions. And in majority of the cases, patients are given combination of medications. Out of these, the combination of opioids or stimulants has a higher incidence of drug overdose. A second number comes to the opioids with benzodiazepine. Now, if we suspect a patient who is having a drug overdose, we have to manage the situation by reducing the doses, by admitting the patient, not abandoning the patient with drug overdose by completely stopping his medications. We have to deal with this situation with a comprehensive care because they can go into drug withdrawals, they can go into more serious problems if it is not handled in a proper way. This is another chart which shows that we have an epidemic of opioid 10 years back. But if we compare from 2010 to 2020, the drug overdose death rates are more than double. So the epidemic is still prevailing. And right now, the epidemic is mainly targeting the prescription drug medications, which also involve other controlled medications like gabapentinoids, benzodiazepine, and other stimulant medications. Another CNS side effects, or I can say long-term side effect of opioid therapy, comes into the addiction and misuse. Addiction needs to be differentiated from pseudo-addiction and physical dependence, because addiction is purposeful. Patient is having a strong dependence, and even if he knows about the side effects, he still seeks for the medication. Most of the chronic pain patients who are on opioid therapy are having this problem, but there are also a group of patients who are pseudo-addicted because their pain control is not properly done, and they are labeled as addicts in the clinic. So it is a very fine balance in which we have to find out whether the patients are really addicted, or they are physically dependent, or they are having a pseudo-addiction. In pseudo-addiction, physical dependence, we have to optimize their pain management and then go further for their management. Now, there are some red flags in which we can say how to diagnose that the patient is addicted or misusing the medications. If we find out that the patient is obtaining additional opioids from other providers, he is having a polypharmacy attitude, it's a very big red flag. And if the patient is coming to your clinic every time with self-modification of those prescriptions, and he needs the medications to the extent which gives him a sedative effect rather than analgesic effect, these are two things which can lead you to think about the addiction in that person. Also, if you find out that patient is using the medications for recreational purposes and he has a habit to hoard the pain medications, we have to look into it seriously. For these, there are certain measures which can be done. If a patient is a high risk or a moderate risk, we can apply patient agreement forms and perform urine drug testings on a regular basis. That can be done every 4 to 6 months, or that can be done at every visit randomly to see we can rule out the polypharmacy, or we can rule out that the medications prescribed to the patients are from the same pharmacy, or he is having prescriptions from other groups. So in the CNS system, I also wanted to talk about something about tolerance. Like every medication, opioids also do get tolerance for the effects. And the effects not only comes to the side effects, as I mentioned, like most of the side effects of opioids, patients do get tolerance over a period of time except constipation. But the patients also get tolerance to analgesic effects after a certain time. Treatment is to optimize the dose of opioids with a balance of optimizing their side effects, or we can do opioid switch. And this can be measured by various scoring systems. Now, next side effects which I would like to speak about is the cardiovascular side effects. And 77% of the patients who are on long-term opioid therapy are likely to have cardiovascular events like MI and heart failure. It's a very, very common thing, and that's how the role of fine balance is needed. We talked about the indications, we talked about the side effects of opioids, but there are certain contraindications or a gray zone. Not even a gray zone, a red line for which opioid should never be prescribed. If you have a patient with a primary headache or a functional disorder, which may even involve fibromyalgia or IBS, opioid should never be initiated, even as a second or a third line therapy. Chronic pain is a major manifestation of a mental disorder, or a comorbid severe affective disorder are a big contraindication, because these patients are not mindful about using the medications properly. If we have a history of medication abuse, opioids are not an answer to any pain control. Besides this, chronic pancreatitis and pregnancy are also contraindications for prescription of opioids in pregnancy for obvious reasons, because all the opioids are having harmful effects on the fetus, and chronic pancreatitis doesn't require the prescription of opioids except for acute control, yes, but for chronic long-term therapy, definitely there is no rule. So I will just like to highlight on some of the prescribing practices when we consider therapy with opioids. Some for the acute pain management, it has to be time-limited use. In our institution, we have made a policy in which opioids can be prescribed only for 3 days without, and above that, it has to be overruled for opioid prescriptions for patients as an inpatient. Now, limit the prescriptions to expected duration because there is no role of opioids more than 3 to 5 days after any acute postoperative event or any other acute conditions. Long-term therapies should only occur after careful evaluation and discussion with regular follow-up with prescribers. Otherwise, acute pain management have role of opioids for a very, very short term. Now, some prescribing practices for chronic pain management is very important because nowadays the prescription for opioids are increasing, but we should have realistic expectations with our patients. They should be informed about the therapeutic goals and the risk of opioids. No, it shouldn't be that, as we have mentioned before, the goal should never be 0 out of 10 pain scores. It should be about improving their functional status. All the patients on long-term opioid therapy, they need to be screened for any affective disorders, depression, psychiatric disorders, and history of substance abuse is very, very important. In all the cases, we should always consider safe alternatives, and patients must be explained that discontinuing opioid therapy may be difficult, but it is not impossible. Now, careful evaluation and weaning plan should be ready. Regular follow-ups of patients are required in the chronic pain clinic, and we should not assume that patients know how to use the opioids safely, because majority of the times, if a person is in pain, he just knows that he is in pain. At that time, he doesn't realize whether the medicine is good or bad for him. Now, do not continue the therapy if there is no improvement, which is defined by any reduction of pain or increase in function. If you find no improvement in 3 months of initiation of therapy, we should not continue the opioid therapy, as we will start to have the side effects without any benefit in those patients. And last but not the least, we should not abandon our patients if we are confirmed that there is a prescription drug problem. We have to find a way, we have to solve the problem, and we have to help these people. But yes, we have to avoid the opioid epidemic in a best possible way by a joint effort. Thank you very much for listening. I'll hand over the mic to my colleague.
Thank you so much, Jaya. That was fantastic. I think the last couple of slides were the nuggets, the golden nuggets that you presented to the audience about the acute pain management and the opiate indications, chronic pain management. And as you said, my take on the overall opiate prescription drugs is, we as a physicians believe in the principle of primum non nocere, which means first do no damage. And I think you would agree that the opiates, if they're continued inappropriately, will lead to a long-term damage. So now, without further delay, I'm going to hand over the virtual podium to my colleague, Dr. Himanshu Chauhan. Dr. Himanshu is an associate staff physician at the Cleveland Clinic Abu Dhabi, and he basically specializes in neuropathic pain, widespread pain syndrome. He's done an excellent talk recently to the Faculty of Pain Medicine in Sri Lanka on the widespread pain syndrome. So, Himanshu, I'm just going to put up your slides, and then we will be good to go. So, let me just share your slides. Here you go. And he's going to talk about the evidence of use of opiates and gabapentinoids. So we need to know, is there an evidence? And if it is, how good is it? So thank you so much, Himanshu. The stage is all yours. Thank you. Yeah, I can see the camera and I can see your slides. You're good to go. That's fine. Okay. You're good to go.
Right. Okay.
Let me turn yeah, that's fine. You're good to go. Thank you.
Hi, good evening, everyone. Thank you, Sadiq, for the nice introduction. Today, I'm going to talk on evidence for use of opioids and gabapentinoids in chronic non-cancer pain. Okay, so the bottom line is there's no evidence of the highest quality that opioids are effective for the management of chronic non-cancer pain, particularly in the long term. And this one. Okay. Sorry. Okay. So as we all know that the opioid use has been since centuries, and it has been used for different purposes. But the pharmacological use started in early 18th century when it was coming as syrups in different forms, oral forms, and they were used for small kids, for sleeping problems, for GI problems, as well as it was, as Sadiq told, that the East India Company, they start making it pharmacologically available, and it was using for the pain as well as recreational purposes like laudanum. So as it was used, but concern was also not new either. You can see in 1851, Davis, who's an MD, he wrote a letter to the general editor of Provisional Medical and Surgical Journals that use of opium for its intoxicating effects is becoming daily more general among the humble but usual classes of society. So the concern was not even, there were always a concern about that. So traditional teaching about the opioids is that opioids are effective for acute pain, as well as they are using, the opioids were very good for cancer pain as well as pain at the end of life. And there always been scarce, there always been a sense that opioids should not be used for chronic pain conditions. But as we see that there are some concerns that we can use it for neuropathic pain as neuropathic pain conditions. So when I put these opioids in non-cancer pain, I could see that till 1994, there were not many papers. But then in 90s, there are huge support for using opioids, and there are a few publications which really strongly support the use of opioids in non-cancer pain. And then gradually, you can see there are a number of publications which has increased substantially for both, which advocate the use of opioids in non-cancer pain, whereas later on in early 20th century, there were papers which are not advocating it, which are against of using opioids in non-cancer pain. So the history, in short, was in mid-80s, 1980s, there were a lot of patients because of cancer, they were dying in pain. And then WHO, they bring a letter for pain which advocates the use of opioids as a second tier and strong opioids for the third tier. There was a pendulum. Those times, there were some people who were advocating the use of opioids for non-cancer pain, but some of them are, they're hesitant to use it in non-cancer pain. But you see, the actual story, it starts in 90s when pain relief was considered as a universal human right, and it was considered in 1996 as a fifth vital sign. And there's a lot of things to be with the pharma companies. The pharma companies, they were advocating the use of opioids for non-cancer pain. Everyone knows why. And the government was pushing it to prescribe, as a pain as a fifth vital sign, and they were pushing that it should be considered, the pain has to be taken care of. And the undertreatment of pain was seen as a malpractice. So there were small trials during that period which shows the efficacy of opioids in non-cancer pain. A real landmark study was done by Rosal, which was published in 1986, only based on 24 cases. You see, and 38 cases. So they conclude that opioid maintenance therapy can be safe, salutary, and more human alternative to the options of surgery or no treatment in those patients with intractable, non-malignant pain and no history of drug abuse. So this changed the scenario. It was pushed by pharmacies, the government was supporting that, and people were advocating use of opioids in non-cancer pain. Probably they were not knowing that what is coming in future, which can lead to a lot of deaths in coming years to humankind. So the another picture, the other paper which comes there is Tragedy of Needless Pain by Ronald Melzek. who is Ronald Melzack. He is the author of Gate Control Theory of Pain. So he advocated the use of opioids in non-cancer pain, and he wrote, contrary to the popular belief, the author says, morphine taken solely to control pain is not addictive. Yet patients worldwide continue to be undertreated and to suffer unnecessary agony. So this changed whole scenario. People start using opioids for non-cancer pain, but as I told, the concern is still there. There was another paper by Robert in 1995, opioids for chronic pain of non-malignant origin. Is it caring or crippling? So they wrote that recently some pain specialists during that time advocated the use of opioids in long-term management of non-cancer pain. And this has raised some fundamental questions about the purpose of pain management. Is it best to opt for maximum pain relief and comfort, or should one emphasize function and activity as high priorities? So they wrote that they hope that patients will not be subject to needless pain, but get opioids if they are beneficial, without raising unrealistic hopes of cure for chronic pain. It is best to opt for maximum pain relief and comfort, or should one emphasize function and activity as high priorities? So, but during that time, in 90s, there were a lot of people who were advocating, and there's a lot of evidence there. For example, they did a randomized trial of oral morphine for chronic non-cancer pain. And on VASCO, the morphine showed reduction in pain intensity related to placebo significantly, Another paper which shows efficacy of oxycodone in neuropathic pain by Watson. It was they show that there is a global effectiveness, disability, and mass patient preference all showed superior scores with oxycodone relative to placebo. Another paper in 2004, which is a good paper, they saw that oral therapy, oxycodone is safe and can be prescribed controlled. So oxycodone is a good alternative in the treatment of non-cancer pain and can be recommended as a first-line treatment for the above-mentioned indications. So during that period, most of the papers published, they advocate the use of chronic opioids in chronic pain. And we know that in coming years, we are going to see the effect of these papers. Opioids in neuropathic pain, another paper, which show it's a meta-analysis of short-term trial efficacy by Eisenberg in Journal of Medical Association in 2005, which shows significant analgesic benefit overall in 8 trials, assessing non-parenteral therapy used for up to 28 days, thus substantiating the efficacy of opioids for neuropathic pain. So, at 2000s, from 2006, when the people have awareness, the more publications start coming up now after seeing the results against the use of opioids in non-cancer pain. So this is there's a good paper, meta-analysis of effective and side effects. It was included 41 randomized trials involving 6,019 patients. 80% of patients had nociceptive pain, 12% has neuropathic pain, 7% fibromyalgia, and 1% mixed pain. So the interpretation was weak and strong opioids outperformed placebo for pain and function in all types of chronic non-cancer pain. But other drugs produced better functional outcomes than opioids, whereas the pain relief, they were outperformed only by strong opioids. So the idea is not pain only, the idea is functional activity of the patients, where these drugs where the other drugs had a benefit over the opioids. So despite the relative shortness of trials, more than 1/3 of the patients, participants, they abandoned trial because of side effects. So conclusion from only RCTs and systemic reviews was that contrary to the traditional belief, chronic pain, particularly neuropathic pain, is opioid responsive, although the larger doses are required than those needed to treat nociceptive pain. They are usually short-term because long-term opioid, they were not getting any benefit if you're using the opioid for long-term. And doses were usually generally moderate when you get that benefit. So there's another meta-analysis by Cochrane database systemic reviews in 2010. They reviewed 26 studies with 27 treatment groups, and they enrolled almost 5,000 patients. The opioids were used orally, transdermally, as well as intrathecally, and the conclusion was many patients discontinue long-term opioid therapy, especially oral opioids, due to adverse events or insufficient pain relief. However, weak evidence suggests that patients who are able to continue opioids long-term experience clinically significant pain relief. So there was strong evidence not to use strong opioid, but there was weak evidence that patients were able to continue for long-term, but there was no significant pain relief. Whether the quality of life or functioning improves is inconclusive. Many minor adverse events like nausea and headache occurred, but serious adverse events, including iatrogenic opioid addiction, were rare. So still, they did a large study, but they're not able to find, iatrogenic opioid addiction, which is, I don't know, which is far away from the reality. So another paper in opioids compared to placebo or other treatments of chronic low back pain. It was published in the Cochrane Database of Systemic Reviews, published in 2013, where the authors conclude that there is some evidence, very low to moderate quality, for short-term efficacy for both pain and function of opioids to treat chronic low back pain compared to placebo. Although they say that there are very few trials that compares opioids to NSAIDs or antidepressants, but they did not show any difference regarding pain and function. This is a very important statement done by the authors during that period. And the initiation of a trial of opioids for long-term management should be done with extreme caution, especially after comprehensive assessment of a potential risk. Now, the opioids for neuropathic pain. Another Cochrane Database of Systemic Reviews, published in 2013, which shows that short-term studies provided only equivocal evidence regarding the efficacy of opioids in reducing the intensity of neuropathic pain. When we used the opioid for intermediate duration, it demonstrated significant efficacy of opioids over placebo, but these results are likely to subject to significant bias because the studies were small size, short duration, and potentially inadequate handling of dropouts. There's another paper published regarding the analgesic efficacy of opioids in chronic pain. So meta-analysis done by Rienke, and it shows that they conclude that opioids alone are inappropriate and multimodal treatment programs may be required for chronic non-cancer pain. So now the evidences are against using these. In the early century, in the late 19th centuries and early 20th century, they were pro, and now there are a lot of evidences, including meta-analysis and systemic reviews, which are against using opioids in chronic non-cancer pain. So the another one published in 2018 in JAMA, effect of opioid versus non-opioid medications on pain-related function in patients with chronic back pain or hip or knee osteoarthritis. It's a spaced randomized clinical trial. It was done for 12 months, compared the use of opioid versus non-opioid for low back pain and osteoarthritis. So they did not find any improvement over 12 months. In contrary, they found that pain intensity was significantly better in the non-opioid group over 12 months. It's a recent paper published in 2018. Another Cochrane database of systemic reviews done by Seattle, published in 2017, which says that for the high dose opioids for chronic non-cancer pain, which says there's a critical lack of high quality evidence regarding how well high dose opioids work for the management of chronic non-cancer pain in adults and regarding the presence and severity of adverse events. Okay, so this is the guideline published by American Society of International Pain Physicians. They have 24 points, recommendations during the procedure when we start the opioid therapy until we stop. So they conclude that chronic opioid therapy should be provided only to the patients with proven medical necessity and stability, with improvement in pain and function, independently or in conjunction with other modalities of treatments in low doses, with appropriate adherence monitoring and understanding of the adverse events. So there are another publication done in the 2-year prospective multi-center study of opioid therapy for chronic non-cancer pain, which includes 674 patients were recruited for this, and this study describes a pattern of increasing. So see, even after so many publications against that, but still they find a pattern of increasing opioid prescription in chronic pain patients. So this is an eye-opening paper, which even of so much evidence, we still have an increasing opioid prescription for the chronic pain patients. So another one published by Chronic Pain Therapy Treatment Opioid Analgesics, Benefits versus Harms, which shows evidence of improved physical, emotional, and cognitive function with long-term opioid therapy is inconclusive. There's another study, meta-analysis using against the chronic opioids in chronic non-cancer pain. And this is a recommendation, recent recommendation published in German, article in German, but I just translated, which shows that opioids remains a treatment option for chronic non-cancer pain if non-pharmacological therapies are not effective, or other drugs are not effective, or are not tolerated, or are contraindicated. Then you can go for opioids. So the bottom line again, from where I started, there is no evidence of highest quality that opioids are effective for the management of chronic non-cancer pain, particularly in the long term. As my other speakers have already emphasized on this, you see the number of deaths happen recently, even after so many evidences against using it in recent years, especially from 2014 to 2020. And most of the deaths were attributed to the prescription drugs. Only in, you can see here, the graph is rising now. Only in last year, in 2022, last 1 year, ending in March 2022, there are more than 100,000 deaths because of drug overdose. So it's really a real concern for us, for physicians, to use opioids in the proper way, especially not for chronic pain. Now for gabapentin, I'll just go quickly briefly about this. The gabapentin, it was discovered in '94, and then it was discovered as for an epilepsy, and later on there are evidences when they start using it for other chronic pain conditions. Same with pregabalin. The use has increased recently from 2000, and then the use it has been used increasingly for chronic non-cancer pain, for different chronic pain conditions. Gabapentin, a new agent for management of epilepsy. It was discovered in '94. '97, they found that it can be useful in some neuropathic pain syndromes. '97, they have used in upper motor neuron symptoms for multiple sclerosis. So the real picture came when there was a publication was in '97 in Pharmacology, which advocated use of gabapentin in pain management, which shows that benefit of gabapentin in neuropathic pain, post-herpetic neuralgia, as well as migraine prophylaxis. Then again, there was another publication in 1999, which says that gabapentin is both a novel anticonvulsant agent as well as it has a potential treatment for various pain states. So again, there is a Cochrane database systemic review, which was published in 2000, which shows that chronic pain syndromes other than trigeminal neuralgia, anticonvulsant should be withheld. Still they were using more gabapentin in trigeminal neuralgia, but still the more evidence has to come to use gabapentin in other conditions. Gabapentin for neuropathic pain, another one in 2001, systemic review of controlled and uncontrolled literature, which shows that gabapentin is effective in multiple pain conditions, multiple painful neuropathic conditions. So gabapentin has well established itself during this time, as well as pregabalin, to be useful in neuropathic pain, like post-herpetic neuralgia and other neuropathic pain, as well as the people start using it in fibromyalgia patients, and they found it to be useful, as seen in this paper published in Cochrane Database Review, published in 2014. So a decade of gabapentin misuse. There was another one where they were concerned about the use of gabapentin as misuse. The present data seems to suggest that gabapentinoid misuse may be a cause for concern, especially in the patients with a history of substance misuse. So it was published recently in 2016. Another paper in 2019, which says that gabapentin can be used and pregabalin are the good drugs which can be used as first line in neuropathic pain. So in 2017, the people start using gabapentin as a post-operative pain also. And they found that gabapentinoids effectively reduce post-operative pain, opioid consumption, as well as opioid-related adverse effects after the surgery. And in 2009, there's another study which shows that gabapentin is useful in fibromyalgia, also has improved sleep and improved health-related quality of life. It's a meta-analysis published in 2009. Another one, Cochrane review for pregabalin and gabapentin for fibromyalgia. And people start using in spinal cord injury for post-spinal cord injury neuropathic pain, whereas there more evidence is coming up later in 2016, 2022, which advocate the use of the gabapentin pregabalin for spinal cord injury patients for neuropathic pain. Same in central post-stroke pain. There are more RCTs, around 1,040 patients published in 2022. It's also a meta-analysis which shows that gabapentin and pregabalin are the most significant. They have good effect and they can be used, but also they are the one which have more adverse reactions. So you have to be careful. But they found to be useful in these patients. Chronic pelvic pain in women. They found that these drugs, they are not still evidence available where we can advocate these neuromodulatory drugs in chronic pelvic pain. It's a very recent paper published in 2022. Again, there's one paper recently published in 2022 which advocates the use of gabapentin and pregabalin for post-operative pain, especially the early pain during 0 to 4 and 6 to 12 hours. But at 24 hours, they don't found any difference. It was equivocal. Same systemic review and meta-analysis of gabapentin and pregabalin for sciatic pain. So they did not find any. They said that there's a clear evidence for lack of effectiveness of pregabalin and gabapentin for sciatic pain management. Contrary, but clinically it's been used, and we found that it is useful for the neuropathic pain. So, how addictive are gabapentin and pregabalin? They did a systemic review in 2017, and based on these results, they found that those patients who have a history of substance use disorders, the gabapentinoids should be avoided, or if indispensable, they should be administered by caution. Again, one paper in 2021 which says abuse and misuse of pregabalin and gabapentin. It's a systemic review update which suggests that gabapentinoid misuse represents a growing trend that is causing significant patient harm. So prescribers should exercise appropriate caution with use in high-risk populations and monitor for signs of misuse and abuse. Thank you.
Thanks very much, Himanshu. That was a very good run-through onto the evidence and on gabapentinoids and opiates. So guys, if you have any questions, please put in the chat box. We will take the question answer session at the end as a panel. Now, next on to our webinar it's a pleasure to invite Dr. Kelly Huffman. Dr. Kelly is a clinical psychologist. She works and we're very, very honored to have a psychologist on our team. The team at Cleveland Clinic Abu Dhabi, the pain management team at Cleveland Clinic, we have a multidisciplinary approach to the pain management, and we do need to have a psychologist involved in terms of managing our patients well when it comes to a point where neither the drugs nor the medications have worked, and the patient has a huge amount of psychological overlay. So who could be a better person to tell us about the importance of psychology in pain management? So Kelly, let me just put up your presentation, and then the stage is all yours. So here we go. I need to just, here you go. Right. So we are good to go. I'm just going to put you on the presentation mode. Are you able to see the slides for me? Not yet? Okay, let me just quickly... This 2 seconds. Right, so let me just stop the sharing first, and then I'm going to there. So
Now again, go back to
Open share.
the next one on the right. No,
Okay, here we
go to the desktop.
I'm going to go to the guest desktop. Yep. Okay. Let's just close this so the things which we've done. Sorry, guys, a bit of a technical glitch, but I'm sure we will be back on. So are you able to see the slides? Great. Fantastic. Lovely. Right. And hope you're able to see the webcam and the mic is on. Thank you, Kelly.
Thank you.
Thank you so much for your time.
Thank you so much, Dr. Siddiq, for that kind introduction and for inviting me to be here tonight to talk about the role of psychology in chronic pain management. I'm very honored to be here and very honored to have an opportunity to present with my other colleagues tonight. The topic I'm going to cover tonight is actually something that I'm very passionate about, and it was my primary role before I came to Cleveland Clinic Abu Dhabi. So I'm a licensed psychologist in the U.S. and the UAE. I have specialized training in pain medicine, and I worked in a chronic pain rehabilitation program for a number of years before coming to Abu Dhabi. So I'm very pleased to be here today and share more with you about chronic pain and psychology. The objectives for my presentation today. So basically, I wanted to cover the questions that I'm most frequently asked, and these focus on, so what is pain psychology and what do I do? When do I refer a patient to pain psychology, and how exactly do I explain this referral to a patient? Because oftentimes patients are resistant to the idea of seeing a psychologist for their real chronic pain. And when you do refer a patient to see me, so what can you expect? So what will I do? What will my evaluation consist of? What recommendations might I make, and what treatment might I provide? One of the most common expectations that both patients and providers have is that I'll be providing some sort of cognitive behavioral therapy. So I'll talk to you also about what CBT is in the context of pain psychology and how this can be implemented as part of an interdisciplinary care. Okay. So I thought I'd start with an abstract from some research that we published on main campus. One of the reasons I wanted to start with this abstract is it emphasizes that pain psychology and interdisciplinary chronic pain rehabilitation programs can be a safe and effective mechanism of providing non-opioid care to our patients. So in this study, we looked at the clinical outcomes of over 1,000 patients on various doses of chronic opioid therapy. So 400 on high dose, around 500 on low dose, and around 500 not at opioids at all. And we looked at their clinical outcomes when they finished a 3-week-long chronic pain rehab program and at 6 months and 12 months post-treatment. And one of the things we found is that patients showed immediate and sustained improvements in pain severity, depression, anxiety, and in functional impairment with no group differences. All of the patients in this program were weaned from opioids. So what this tells us is patients on high doses of opioids who were weaned from opioids obtained the same benefits from treatment as patients not on opioids or on low doses. Moreover, the effects of this treatment were medium to large in size. And there were actually good statistics about resumption post-treatment. So about 10% of patients who weren't on chronic opioid therapy resumed some sort of PRN opioid therapy, and about 30% of patients who were on opioids were able to remain opioid-free 12 months post-treatment. So that's sort of the takeaway, is that patients who've been on high doses of opioids for long periods of time can be safely, effectively treated as a part of interdisciplinary care. I wanted to talk to you more about pain psychology. I know Dr. Siddiq highlighted this nicely. So this is actually one of the first things I talk about with patients is this idea of what is pain. And I highlight that pain is an interaction of the bio, the psycho, and social, so the biopsychosocial model. Patients often find this comforting because one of the first things I'm doing is validating that their pain is real and their pain is physical. And because they've been referred to me, that does not mean that their pain is psychogenic. So I emphasize that pain is personal and influenced by all three of those factors and a concept we've learned through life experience. So what can you expect as a provider? So you've referred a patient to pain psychology. What am I going to do? So the first appointment is always an initial assessment. So it's an in-depth evaluation. So we'll cover the pain itself, but I'll also take an HPI with a psychological focus. So what were you doing at the time of onset of the pain? How has it impacted you? What psychological factors make it better or worse? So for example, stress. What does the pain mean to you? What treatments have they had? What medications? Their degree of functional impairment? Their emotional response to the pain itself. Often patients are depressed and anxious because of the pain, and they will want to emphasize this to you. So I'll look at their emotional response as well as psychiatric history. I do think of these things as different. Substance use, psychosocial history, and family response. Of course, I'll give diagnostic impressions, but one of the most important pieces, I think, are individualized recommendations. So what do I have to offer to help treat the pain? So this could be CBT, pain education. This could be treatment of comorbidities. So perhaps they also have an anxiety disorder or post-traumatic stress disorder. Maybe they have an opioid addiction. I might recommend individual, group, or family therapy. There's usually a CBT component, but I'm also a big fan of psychodynamic therapies. I might offer family work. I might address things such as secondary gain or enabling, arousal, mindfulness, and I will make recommendations regarding level of care. So can this patient be treated as in an integrative clinic as an outpatient, or do they need something more intense, such as a multidisciplinary program? One of the other things that I spend some time talking about or thinking about during the evaluation is chronic pain syndrome. So I want to emphasize a patient does not need to have chronic pain syndrome to see me. Of course, I can see these patients, but we can also treat people who do not have chronic pain syndrome. I think of chronic pain syndrome as important in determining level of care. So chronic pain syndrome are these patients with marked pain behavior, significant distress. They're usually quite depressed and anxious. And the functional impairment related to pain is disproportionate to the objective physical findings. Usually there are psychosocial dynamics that are set in motion by this chronic pain syndrome, such as family dysfunction. So perhaps family members are hostile or angry, perhaps family members are enabling, and these patients often excessively utilize healthcare. So I might look at chronic pain syndrome. Another topic I routinely cover is problematic use of habituating medications. As Dr. Jaya highlighted, so tolerance and withdrawal are not considered criteria for opioid use disorders. And we look at the DSM criteria a little bit differently. So typically we would consider these in recreational addiction. However, in iatrogenic addiction or therapeutic opioid use disorder, it looks a little different. The DSM criteria can be broadly lumped into what I think of as 3 different categories. So loss of control, consequences, and cravings. And I've put here a description about what this might look like in a patient with chronic pain undergoing chronic opioid therapy. So sometimes what you'll see is they have an intense, persistent desire for the drug, an overwhelming concern about it. And this concern can actually impede progress with other issues or treatment options. So sometimes people will be very focused on opioids and opioids alone, to the exclusion of things like physical therapy or injections or even psychology. So you'll see an inability to comply with the prescription regimen. So sometimes they'll run out early. Sometimes they'll treat symptoms other than pain. So you'll hear people say things like, this is the only way I can sleep, or perhaps they're using them to treat emotional distress. And one of the hallmarks, so I think number 5, is so people will continue to request opioids despite it being a failed treatment. And I think this is really important. So you'll see people that say, you know, my pain's an 8 out of 10, it never changes, I can't go to work, I can't go to school, I can't participate with my children, but they're still on high doses of opioids, and they still continue to desire this treatment despite the fact that it's a failed treatment. For me, this is always a red flag. Because people don't often insist to continue other treatments that aren't working. So the rest, I think, are obvious. So continued use despite adverse consequences, using other substances in addition to the opioids. But so these are some of the things I look at in evaluating whether or not a patient has an opioid use disorder. Some of the things I might recommend, so individual, group, or intensive chronic pain rehabilitation interventions, depending on the degree of impairment. So individual psychotherapy, a typical course might be 8 to 12 sessions. Many people do need longer. We can also offer group single session classes. And in both the individual psychotherapy and groups, some of the components we cover might be pain neuroscience education, mindfulness, CBT skills, relaxation training, biofeedback, relapse prevention, and a self-soothing action plan. There was an interesting study that came out recently that showed some of these group education classes are actually non-inferior to 8 individual sessions of CBT. So these can be quite effective. If a patient has a significant amount of functional impairment, often or on high doses of opioids, often an interdisciplinary chronic pain program might be needed. We actually don't have one to offer here at CCAD, or I'm aware of in the region, but these are typically intensive all day long, every day, 3 to 4 weeks. They might include opioid weaning, medication management, PT, OT, pain psychology, a physician, nursing, and they've been shown to be safe and effective. One of the questions I'm most often asked is, what is CBT? So people will refer people for pain psychology CBT. I have an umbrella here to emphasize that CBT is actually a large umbrella term that covers many different techniques. So things like cognitive restructuring, behavioral change, it could be biofeedback, relaxation. When I'm offering CBT, I will make some individualized recommendations about what might be best for that patient. One of the principles that all of the different techniques in CBT have in common is an underlying theory. So the whole idea of CBT is that what we think, what we do, and what we feel are bidirectionally and reciprocally connected. So if you change one part in the system, you can change the other two. So you'll see here what we refer to as the CBT triangle that emphasizes the linkage between thoughts, feelings, and behaviors. In psychology, we most often focus on identifying negative thinking patterns. So something that you've probably heard of that's quite popular is actually identifying cognitive distortions, and the idea that these cognitive distortions lead to negative emotions and behaviors. But in actuality, we can intervene at any part of the system. It's just we tend to most commonly focus on thoughts. One thing I want to emphasize today, if there's one particular thing that I hope you take home today, is that thoughts about pain matter. So what patients tell themselves about pain impact how much pain they experience and their level of disability. One of the most common types of thoughts that I target that are specific to pain is the hurt versus harm distinction. Now, you all are quite familiar with this as pain providers, but our patients often don't know the distinction. So they only recognize one kind of pain. So to them, pain means something is wrong, there's something dangerous happening, and there's something that needs to be fixed. So patients will tell themselves things like, there must be something wrong, and this leads to feelings of anxiety and fear, and a behavior we might see from that is excessive healthcare utilization. So if you remember in the previous slides, I talked about how we might provide patients some pain education. One of the things I often talk to them about is the hurt versus harm distinction. So I have here some of the characteristics of acute pain, and I'll talk to patients about the implications for treatment. So acute pain signals the need to rest, the need to fix pathology. There might be indications for opioid analgesics and less attention to psychological factors. Most times, patients are often convinced their pain is acute. And then I talked to them about chronic pain as a disease state itself. So we had a very nice presentation in which we talked a little bit about central sensitization and some of the alterations in the structure and function of the nervous system. I'll provide patients some education about this as well. And I will emphasize this pain is real. It has a physiological basis. However, it's no longer useful as a warning signal and does not signal ongoing tissue damage. And I'll emphasize to patients it's possible to have real pain despite the fact that the underlying cause has been treated and healed. And it's often useful to explain to patients how these two different types of pain are different disease states that offer different implications for treatment. So with chronic pain, an active approach, non-opioid and adjuvant analgesics, psychological and psychosocial factors are important, and often treatment will involve family and friends. So this is one type of cognition I like to address in CBT. A second one that's actually extremely important is pain catastrophizing. So this is when people ruminate about the pain, magnify the pain, and create a negative meaning about the pain. So a really common thought is, I'm going to become disabled. And again, this can lead to negative feelings such as anxiety or helplessness or activity avoidance. Pain catastrophizing, so I have the definition here, characterized by the tendency to magnify the threat value of the pain, to feel helpless in the context of pain, and a relative inability to inhibit pain-related thoughts in anticipation of or during a painful encounter. So I have 3 different types of pain catastrophizing: magnification, rumination, and helplessness. And I've offered some examples that your patients might say to you if they're struggling with pain catastrophizing. Pain catastrophizing is actually quite important because higher levels of pain catastrophizing are associated with heightened pain. This is one of the most consistent findings. It's true in both individuals who are healthy and do not have chronic pain and those with chronic pain. When people struggle with pain catastrophizing, they have more emotional distress and more negative affect. Increased functional impairment, and this is when you start to see the alterations in social support networks such as family. Pain catastrophizing is associated with increased pain and illness behavior, including increased healthcare utilization and, importantly, increased suicidal ideation. Pain catastrophizing is actually an important predictor of post-surgical outcomes. So patients with higher pain catastrophizing scores have higher pain catastrophizing scores pre-surgically, have higher post-surgical pain ratings, more likely to have persistent post-surgical pain. They have a longer recovery time, and they're more likely to use perioperative opioids and continue to use opioids 1 to 2 months post-surgery. And if I had to highlight any one takeaway, pain catastrophizing is actually more strongly related to mental health, quality of life, and social functioning than pain severity. And that's a very important takeaway. And then one of the final aspects I'd like to highlight about how patients think about pain is the emotional experience. So you'll see in the thought, they're talking about the pain being vicious or even cruel, and patients might feel angry or sad. Behavior, sharp language is my polite euphemism. Sometimes people will say rude things to their family or friends. It starts to impair their social relationships. This was actually first highlighted, pain being a sensory and emotional experience in the McGill Pain Questionnaire, which is actually developed by Melzak, who later developed gait control theory. So it assessed pain in 3 dimensions, including an assessment of severity, intensity, emotional impact, and significance. So you'll see the sensory aspect, the descriptions of what the pain feels like, but you'll also see the affective aspect. So is it exhausting, sickening, cruel, terrifying, even, and evaluative? And again, this is based on gait control theory. I like to highlight this to my patients, the idea that pain is different than suffering. So pain is the sensory experience, suffering is the sensory experience coupled with the affective and evaluative experience. And I might not be able to take away the sensory experience, but we can work on the affective experience, and sometimes patients can find some relief. I mentioned gait control theory briefly. So gait control theory was actually a revolution in how people think about pain. So prior to gait control theory, I have this old pain pathway, Descartes, 1664. They thought pain was directly proportional to the stimulus magnitude, and if there was no fire, there's no pain. But now we know it's not a one-to-one relationship. Now we know that it's much more complex. So in summary, gait control theory highlights the central control, the input from the periphery, along with cognitive control. So what you can see in the slide is that there's actually a descending inhibitory to control, so signals that our brain sends down the spinal cord that either open or close the gate and determine how much input from the periphery we allow in. So essentially, our cognitive control can modulate how much pain we experience. Gait control theory simplified, so open gait equals more pain, closed gait equals less pain. So you might ask what influences the gait. So we know stimulation of the large nerve fibers can help to close the gait, but we also know things like thoughts and feelings, so our expectations, whether or not we're anticipating pain and context, all of these things influence how much pain we experience. I've included two photos here, which I think illustrate this nicely. So for those of you who have children, you probably remember the first time you took your child to the doctor to receive a vaccine. You'll see the top picture, the baby's looking at it with curiosity. They don't quite know what to expect. And then you'll see a few years later, after there's this learned dimension of pain. So this child below is expecting pain and anticipating pain. And these heightened expectations and anticipation actually make the shot more painful when it occurs. And then finally, gate control theory, social risk support. So I'm going to show you some interesting slides that talk about how social support can actually help mediate the response in our brain to threat, so a neural response to pain, and how social rejection actually amplifies some of the same centers in the brain that pain does. One other thing I might assist patients with is biofeedback and relaxation. So this can be used to address sympathetic nervous system activation, so overall hyperarousal. One of the ways I like to use biofeedback is actually to help a patient become aware of their generalized level of stress. So sometimes you'll see people, they're sort of on edge, stressed, overactivated all the time to the extent that they've become aware of it. It's their baseline. So with biofeedback, we can monitor their physiological processes, so their heart rate, blood pressure, peripheral blood flow, muscle tension, and train someone to become aware of the involuntary workings of their body and use this feedback, so the biofeedback, to help work with them to reverse unhealthy states. We can also use this in combination with psychotherapy. One interesting thing is when someone is hooked up to a biofeedback machine and they're talking about some of the stressors in their life. So sometimes you can see a direct relationship between decreased peripheral blood flow, so decreases in skin temperature, increased heart rate, and increased muscle tension. So this can help highlight to patients the interaction, so the synergy of the mind and body and how this is related to chronic pain. And finally, as I promised, I have a couple abstracts with you to share how social factors are important. So this was a really interesting study of someone I actually had an opportunity to work with when I was a student, an old supervisor, who looked at married women in an fMRI machine, subjected them to the threat of electric shock. And one of the things they found is the quality of the marital relationship moderated attenuation of activation in these systems. So if a woman was holding the hand of a husband that she had a good relationship with, there was lower neural activation in the right anterior insula, frontal gyrus, and hypothalamus. So the quality of the social relationship actually helped to mediate the neural threat of electric shock. Another interesting study I'd like to highlight is that social rejection shares somatosensory representations with physical pain. So what this means is they had people who recently experienced a breakup view a photograph of their ex-partner and had them think about being rejected. And one of the things they found is the areas that support the sensory components of physical pain actually became active when they were thinking about this painful breakup or social rejection. So there's actually an overlap between our social experience and pain. And for this reason, one last thing that I think is quite important is working with family. So helping to repair family relationships and helping to strengthen them can actually help people to deal with their pain response. But often we'll see in families when someone has chronic pain, there's familial dysfunction. And typically this starts out in the best possible way. So family members want to be supportive and caring. So they'll do the things for someone that they usually do when someone is sick. So taking care, helping with them things, encouraging them to rest and relax. It's this very normal response that can actually become problematic with chronic pain with the long term. So if someone's pain's never going to improve, it's not healthy for family to continue to fulfill these roles for them. And over time, this can erode the self-esteem of the person with pain, which is what I'm referring to with hostile dependency. So perhaps they become dependent on family members, but they feel quite unhappy, angry, and sad about it. Often we work with family of origin issues. So in addition to CBT, I like to take a psychodynamic perspective in my work. And then finally, behavior modification. So we encourage family members to ignore pain behaviors, reinforce healthy behaviors, and validate the individual, and reinforce emotional expression and healthy behaviors. Okay. I want to thank you for taking the time to be here with me today. And I've left you with one last slide, the physical and psychological cycle of chronic pain. And I'd be happy to take any questions that you might have. Thank you so much.
That's fine. You can leave that on, Kelly. Right, guys. So I am conscious of time as well. I think we have some questions, and we will take them one by one. I have my whole panel here. As you can see, we're all sitting here and trying to kind of, So I'm very glad to be a part of an excellent team here at Cleveland Clinic Abu Dhabi. We are the top one hospital in United Arab Emirates, which was announced on Newsweek. Our pain management team, just to give you the background, our pain management team, as I said, is a multidisciplinary pain management team. We provide all kinds of therapies, basic therapies including radiofrequency, cryotherapy, also provide regenerative treatment options like platelet-rich plasma, and we have advanced therapies like neuromodulation, including spinal cord stimulation, as well as DRG stimulation and cryotherapy. So we have whole spectrum of pain management options that we provide here. So going on to the question side of things, I think the first question I have here on my computer, I'm actually using two screens. So the first one is saying methadone and ECG follow-up frequency. So I think, Amit, you should be able to take that question.
I'll take that question.
So go for it.
So when you start a person on methadone, you want to check whether he have ever had any ventricular fibrillation in the past or no. You check a ECG and see if the QT interval is more than 450. If it's more than 450, you do not start. If it's less than 450, well, you can start. First, ECG should be checked between 2 to 4 weeks, and then as you increase, when you reach, if you start at a low dose around 5 to 10 milligrams per day, you can keep at that level. But once you reach 30 to 40 milligrams or 50 milligrams, that's the next jump. And then again, check a QT before that. Once you reach 100 milligrams or above, you check it. And anybody who's on 100 to 120 milligrams per day, you check the ECG annually.
So I think the take-home message is do a baseline ECG. Having said that, I worked with the psychiatrist, and we ran a iatrogenic de-addiction clinic. And there are so many antipsychotic drugs, believe me or not, they are much more cardiotoxic, leading to prolonged QT interval as compared to methadone. Methadone is considered a very safe drug, but it's always better to do a baseline ECG and then titrate the dose slowly. And if the dose jump is high, that's where you'll do another ECG. Moving on to the next question I have here, choice of post-op analgesia in drug misuse patients. I think Jaya was going to take this, and I will make some comments as well.
Right. So drug misuse patient, if we are having it for any surgery, we have to keep in mind that we have to balance the analgesia as well as avoiding any drug withdrawal symptoms. So we have to utilize a multimodal approach to manage pain in such patients by using regional anesthesia techniques, by maybe use of ketamine infusions during intraoperative periods, and the baseline medications which the patient is using preoperatively are not considered a part of the analgesic regimen. The analgesic regimen is always to be tailored upon that baseline medications which he is using preoperatively, because we have to balance the patient can have excellent pain relief with any regional anesthesia technique done intraoperatively, but he can have withdrawal symptoms if we are not balancing the preoperative drug on which he is abused, or whatever he is abusing or he is dependent upon. So the analgesia does require the preoperative substance which he was using, along with added analgesia in the form of multimodal management. Sadiq, you want to comment something?
So I think, as you said rightly, Jaya, it is multimodal analgesia, and there's a huge amount of focus nowadays on opiate-free analgesia. If you ask me, I think opiates are a good drug if you use it appropriately. Part of the opiate-free analgesia include using drugs like ketamine, IV lignocaine infusion, magnesium, regional anesthetic blockade. But I think the most important bit, your work starts when you see this patient in pre-op, because anxiolysis plays a very important role in pain management. And we've all seen this when you're trying to put a cannula in a patient who screams and everybody outside the theater hears that. I bet you will find that the patient will be screaming in the recovery after surgery if you haven't maintained an anxiolysis. So it's very important to treat patient as a whole. and work with the multimodal analgesia technique, including the regional anesthetic technique. Moving on to the next question, I'll take this one. Is any role of adjuvants in analgesia in ICU? I think, put it this way, when you deal with the ICU patients, there are two important aspects. One is the sedation bit. The other one is the anxiolysis and the analgesia. Now, there are multiple adjuvants that you could use. Clonidine has been successfully used in the patient, which are difficult to wean off the sedation, like fentanyl and morphine. If they've been on fentanyl and morphine sedation for a long period of time, you will realize it's very difficult to wean off these patients, and you'll find a huge amount of sympathetic overdrive. And I think that's where you would try and use the medications like clonidine, ketamine. And as I said, a lot of studies are coming out. And Kelly rightly mentioned about the psychology. And I like the picture where she showed children when they're having the first job. It's curious, second job. They have trained their psychology, and now it's going to be perceived as painful stimulus. But there are a lot of studies coming out, virtual reality applications as well. And I think that's something that's going to change the future. And we are actually looking forward to collaborate and run a study in virtual reality in pain management here at Cleveland Clinic soon. So watch out the space. Now, moving on to the next question we have here is how do you manage post-op pain in recovery room with patients who are taking methadone on a daily basis? Now, I think we all know the answer. So given that you've told about the pharmacology and the evidence and all that, Himanshu, do you want to take this?
So basically, how do you manage post-op pain? So sublingual buprenorphine is a good choice we can use here. And we can use, of course, in these patients, we can always use regional techniques, which is a good thing to do in these patients. And in this way, we can, especially the methadone patients, and we don't want to give them, string opioids and other types of opioids. I think sublingual buprenorphine is a very good choice in these patients. Although it's not available here, but if it is available in this region, I think we should definitely go for that. Sure. And regional techniques, as I said, good option.
And we need to continue the methadone, which on a routine basis.
So I think acute post-op pain in the patients or opiate dependent is a completely different ball game. So I think your aim would be to continue the background infusion or background pain relief to prevent the withdrawal, and then you want to top it up by either an IV agonist like fentanyl or morphine or a regional technique or the sort of opiate sparing drugs like pregabalin or ketamine. Right, moving on to the next we have is any role of new alpha-2 agonist receptors as an alternative to pain medication. So I think Amit, you wanted to take that.
Yeah, so the alpha-2 receptor agonists we have are clonidine and tizanidine. Tizanidine is primarily used as a centrally acting muscle relaxant, and it does. I've seen very good results in patients. Whenever you cover a person with who's given gabapentinoids, along with that, whenever you add tizanidine, patients do have a holistic pain relief. Clonidine also has been used as a chronic pain relief medication, and also in patients where you're looking to supplement a medication to avoid opioid withdrawals. So yes, alpha-2 receptor agonists do have a role, and they are being used regularly.
So yeah, we do use it in our clinical practice. Especially tizanidine is a very commonly used medication in pain clinics for patients with back pain and muscle spasms. Okay, so moving on to the next one, we have a question for Kelly. Great talk. How do you manage unique societal factors which... Okay, I'm going to read that out for you, Kelly. That's slightly longer.
Thank you.
So it says, how do you manage unique societal factors which could be seen in the East compared to West, where societal expectations of taking care of relatives with pain and traditional expectation that patients should rest if they're unwell most often leads to fear avoidance behavior and physical deconditioning? I think that's a very, very good question.
So I'll start by emphasizing I don't know that I necessarily see this as unique. So this is something that I encountered commonly in the West as well. I do know it's more common here, but it's not a unique dynamic. So one thing that I'm particularly keen on is having family members involved in treatment. So after I establish a relationship with a patient, I'll often encourage them to bring their family members in, and we'll talk to them about some of these dynamics. So sometimes I'm often able to provide them some education about things like physical deconditioning or enabling or learning to live with the chronic pain. And if you can frame it in a way that these are the things that they need to do to help their family member feel well, and give them some neurobiology or some explanation for it, often people are more accepting. So you're absolutely right. This is a really important factor that we need to work with in order to help people get well.
That's great. Thank you so much, Kelly. That was a great one. Okay, I think we missed one question here, guys. Should gabapentinoid be used in perioperative treatment of pain to be reconsidered, considering increasing evidence of harm? So I think, Amit, given that you've told about the pharmacology, and I think Himanshu has already gone through the presentation and the evidence, but what's your take on it? Would you use it for acute pain?
Well, so he's talking about perioperative treatment of pain, right? So, I mean, I think recently there was an article which said that there was no strong evidence of using gabapentinoids for the post-operative pain. So, I don't think that there is any strong evidence of using them at this point. That is one factor. But then I am a little concerned about your stressing on evidence of harm. So we still do not have any strong evidence of harm against them. They are very good medications which are used to avoid higher doses of opioids being prescribed. And there is no long-term life-threatening harm with gabapentinoids. They're pretty much good drugs. So they should be taken as medications which are supportive. But yes, we have to be cautious. The way we have to be cautious with opioids, we have to be very cautious on the way gabapentinoids have to be used, and I would recommend them in chronic pain management. But we have to be watchful. We have to take into consideration all the red flags we see in other patients, looking at whether they are looking at drug seeking or opioid diversion or opioid misuse. But yes, as far as perioperative use is concerned, there is no strong evidence of them being used. For chronic pain, yes, there is a strong evidence to be used. Harm, there's not much of harm as yet. So we have to be carefully be using them.
Obviously, I think, as you said, perioperative pain management, if you're talking about reducing the post-op opiate use, people have been using it. I think it most likely works as an anxiolytic and reduces the peripheral sensitization as well as central sensitization. And I think that's where pregabalin has some role rather than gabapentin, given the linear pharmacokinetics of pregabalin. And I think Amit highlighted the new gabapentin drug that's been basically trialed in the US and in Japan. So I think there is a role, but yeah, does it do harm in short term? I don't think. Yeah, long term may do. Having said that, given that the anxiolysis is a bigger problem, I'm sure Kelly will agree. Anything, and I worked with a psychiatrist, and he said anything that reduces your anxiety, you're more likely to be dependent on it. It may include the sugar. So if somebody eats donuts and that reduces their anxiety, more likely they're going to be sugar dependent. Same way it works out with smoking, right? Nicotine reduces the anxiety, more likely to get alcohol, more likely to get dependent on. So anything that has a factor of reduction of the anxiety
and pleasure
and gives pleasure, you're going to be basically going to be dependent on it. I think, and pregabalin is a very good, strong anxiolytic, and I think psychiatrists use that for severe anxiety. So, yes. Okay, guys, so I think we have taken all the questions, so we really appreciate you tuning in.
We have just one last question here.
I think we have the last question. Why is opioid contraindicated in chronic pancreatitis? Okay, so I think the issue with chronic pancreatitis, majority of the patients we see with chronic pancreatitis have a strong history of alcohol abuse. I think that's one of the commonest reasons that they get chronic pancreatitis. And if they have alcohol dependence, then you do not want to start them. And that's one of the opiate risk too, where you would like to ask them about not only the history of that patient, but the family history of smoking, alcohol abuse, because those patients, if they have a family history of smoking alcohol, they're more likely to be dependent on the opiates. So I think you want to actually screen those patients with opiate risk too, and that's why you don't recommend using opiates for patients with chronic pancreatitis. You want to do interventions, and that's our next part. So interventional pain management in the form of splanchnic nerve blocks could be a good way to provide the pain relief, but at the same time prevent the opiate dependence and addiction issue. And I think we're gonna stop, guys. Thank you so much. It's 8:15. We try to keep up to the time. I know we have slightly overrun, but thank you very much. So we will be basically announcing the part 2 dates. There will be an advert on the social media platforms, and so please join us on part 2, where we'll be talking about the interventional pain management approach to pain, including the basic interventions and the advanced interventions, including neuromodulation. Thank you so much. Thanks a lot, and have a good evening. And we see you in part 2. Thank you.